Hi, this is Khaldun Al-Aswad from Henry Ford Hospital. I am presenting CTO Hacks, how to perform CTO PCI in a complex patient using one guide catheter if you have to. I prefer not to use one guide catheter, but if you have to, you should be able to do it. So this is a patient who is in his 60s with severe three vessel disease, ischemic cardiomyopathy, dead myocardium in the apical area, turned down for surgery. His RCA is chronically occluded and his circ has significant disease. He had received stent in the proximal circ right there. And that stent might be a little bit undersized, but it's actually has an adequate lumen. So we started with 45 centimeter sheath, 8 French, EBU4, also 8 French guide catheter, and our target is to wire the biggest OM branch. This is the OM branch, which is really reaches the apex. This is the third OM. This is the first, and if you notice, every branch has significant disease. In patient with ischemic cardiomyopathy, you better not lose any side branches because that's 10% of the myocardium if the side branch is 7.5 centimeter long, meaning 3 inches. So if you patient has EF of 30% and you lose 10% and 10% and 10%, you end up actually harming the patient. So if you notice here, we attempted to go into the second obtuse marginal. Finally, we failed. I did not want to start the branch, so I said, okay, let me see if I can do a HDR. So here it looks like we took a side branch with the wire, and there is actually a perf, but this is very contained, so we kept going. And because it was very difficult to do anything and deliver the balloons and the microcatheters kept sticking, so we performed rod ablation with 1.5 millimeter burr to rod ablate a significant lesion in the third obtuse marginal because that was heavily calcified and even resistance to wire passing. So then we wired the first obtuse marginal. This is at 14 to 16 atmospheres with a significant waste. I took an OPN balloon, and OPN we took, you go undersize a little bit and you go to 45 atmospheres if you have. I did go to actually 50 atmospheres. And if you notice, the waste is gone. Then we were able to deliver a score flex balloon, a scoring balloon, basically to open the waist fully. And this is a 3 millimeter balloon. So now we have wire in the first obtuse marginal, second obtuse marginal, and I actually, this is third obtuse marginal, and I wired those posterolateral branches. And we had to use a fielder FC and a microcatheter to be able to get into them. At this stage, I attempted again to go in the second obtuse marginal, which is a long vessel, reaches the apex antegradally, but still I couldn't, and I did not want to knuckle and start it because re-entry was not really an option because of diffuse distal disease, now no port target. So we went retrograde, and there was collaterals from the diagonal. When you do tip injection in the collaterals donor, I do it in multiple view before I take off the syringe. So I took it in this view, I took it in this view, which is a cranial. This is not really good. So I went back to the other view, and now we're going to cross with the wire. The best wire to cross epicardial collaterals is Suho wire. It's a 0.3 gram tip wire, and this is real time. If you notice the movement of the wire, this is a wire not buckling, not stalling, not inducing PVCs, that meaning it is where you want it to go. If the wire feels like sliding, that's the right direction. If the wire feels like digging, that's not the right way. So this is how you see the wire. Then you advance your microcatheter. It was when you have a single guide catheter, it's hard because when you push the microcatheter, it actually kicks the guide back. But we were able to advance the microcatheter as high as possible, and at this stage microcatheter probably ran out of length, so I needed to do a maneuver to be able to switch to integrate. So the Suho wire is not really a good wire to wire the guide catheter, so I exchanged it to Fielder FC with a mild bend, and I was able to kind of wire the guide with a Fielder FC. If you notice here, the wire is moving. After we wired the guide catheter, now the Fielder FC is an excellent wire for to do tip injection. When you do tip in, to do tip in. So when you do tip in, you basically put the microcatheter integratedly in the guide in a curve, and you come back with the wire, and I literally wired the microcatheter with the Fielder FC. So at this stage, you advance the microcatheter. So this is antegrade microcatheter, this is retrograde microcatheter. So what you do, you pull your retrograde microcatheter and you advance your microcatheter. And be careful when you spin the Corsair, because you don't have a wire at the hub, it might coil. So you just kind of be careful, make sure it stays straight. So I'm advancing the antegrade microcatheter and the same time pulling the retrograde microcatheter. And here we pulled the wire and we wired integratedly, and now we don't have to worry about retrograde wire anymore. We took it out. So basically, after that, it was smooth sailing. We ballooned this big marginal branch here, if you notice, like a very large myocardial territory, and we stented it from the big marginal branch all the way to the mid-circ. Here, I used drug-coated balloon in the first obtuse marginal and the second obtuse marginal, and I ballooned those marginal branches, and I got an excellent result. And this is not only gave me an excellent result, I have an excellent collaterals here to go in the RCA when I come back to open the chronically occluded RCA. I'll be checking the outcome of my results here in about a month or two to make sure that there is no restenosis in the first obtuse marginal or second or third or even the posterolateral branches. If they still have TB3 flow and they have a good flow in them, we're good. We can actually do probably touch up. This is negative remodeling because of the chronic occlusion. If it's still like this, I might touch it up. So in summary, when you are performing left circumflex PCI, you have to be prepared to maintain all the branches, and it's always as it feels like multi-vessel PCI because the left circumflex is small with multiple branches, and you better not lose any branches.